Okay, we're a few minutes past the hour. Why don't we get started? It's a real honor to have Professor Nick James with us here today from the UK. He's globally renowned for his impactful work in the treatment of prostate and bladder cancers with trials such as BC2001, validating an important approach of bladder-preserving trimodality chemoradiation using hypofractionation. And of course, his work with the STAMPEDE trial has permanently changed how we treat prostate cancer. From my recollection now, with more than 10,000 patients on the trial, I think we're just scratching the surface. I'm really excited to see how the future results will continue to shape the modern standard of care for locally advanced or just advanced prostate cancer in general. Without further ado, here's Professor James. Just as one quick point, if you have questions during the presentation, please feel free to punch those questions into the chat box and we'll address them towards the end of the presentation.
So thank you very much. So great pleasure to be here, and thank you all for dialing in, or whatever the word is for a Zoom call. So I'm going to say a bit about the STAMPEDE trial, and it's now been running since 2005, and we're actually approaching 12,000 patients in the trial now, so the numbers keep growing. We're currently paused to recruitment actually because of the COVID crisis, which is actually giving us a bit of an opportunity to have a restructure and a reboot. So what, these are my disclosures. So I'm going to say a bit about the trial design itself, the multi-arm, multi-stage trial, and I'm sure some of you might have heard some of the bits of the talk before, so my apologies for that. But I think the trial design itself is interesting in terms of the principle for how we do studies. I'll then go on to say a bit about systemic therapies for ADT. So again, these are topics you're going to be familiar with. So I'm going to focus on specific sort of aspects of this from the STAMPEDE trial rather than the totality of the data, which I'm sure you are all aware of. And I'm then going to move on to treatments of the primary, and also the issue of volume of disease, because we've tended to, a lot of the literature is focused around the charted classifier, which is kind of a bit arbitrary, really. There's no particular reason why 3 is the magic number in terms of numbers of Mets as to where you might want to put a cut point for high versus low volume. And secondarily related to that is the issue of actually how much does volume of disease matter in treatment choices. And I'll also say a bit about combining treatments. So just starting with multi-arm, multi-stage platform, whatever you want to call them, trials. So in general, when we do trials, as everybody knows, it takes a long time to test things, often many years. If you want to add in things like biomarker stratification, it gets even more difficult because you make common diseases a collection of rare diseases, and traditional trial designs don't necessarily cope with this very well. So just to sort of give you a sort of very brief overview, the way that we usually approach these things is to do, sorry, oh gosh, wait a minute, I've got my thing is on an automatic timer. A series of phase 2s and select agents that we think might be worth going forward and then put them in phase 3. What we've done in STAMPEDE is to combine the stage 2 part of this. Sorry, I'm just going to stop the show a second. I seem to have an automatic timer thing on this, and I don't know how to turn it off. Does anybody know how to turn it off? I can't. That's it. Right. My apologies. Right. Is to do phase 2 trials, select agents, which you then take into phase 3. So in this cartoon, we've done 7 trials. One drug didn't look very promising, so you didn't do the phase 3. These phase 3 trials are all competing with each other for patients, for resources, for everybody's attention. So what we did in STAMPEDE was to combine, for the early arms in particular, the phase 2 with the phase 3 parts, and use interim analyses based on an intermediary outcome, failure-free survival, to select which agents we continued through and which ones we ditched. Now, so that's the sort of basic design. So now we've just got one trial. We've only got one control arm instead of 3 control arms for the phase 3 parts of it. So it's more efficient in terms of this, not avoiding the stop-starts between the phase 2s and the phase 3s, and also not putting lots of patients into control arms. Now, in general, if you're a patient and you want to go into a trial, you want to go into get the new treatment. Nobody goes into a trial wanting the control arm. So having a trial where you've got multiple experimental arms and only one control arm is very attractive to patients, which I think is one of the reasons the recruitment has been so good, is because you've got more chances of getting something novel. So this is just to illustrate how that's worked. This is how the trial started. We wanted to look at docetaxel, zoledronic acid, and celecoxib. So one of the themes we've explored all the way through is repurposing existing drugs. So for zoledronic acid, it was a partial repurposing. For celecoxib, it was based on observational data suggesting that non-steroidals reduced your risk of cancer and lowered your risk of metastases. And we figured there were enough patients out there to look at some combos as well. So in orange is what we set out to do. We started in 2005, so the top of this has gone astray. We got to the second interim analysis and the celecoxib arms were dropped out on the basis of lack of efficacy on failure-free survival. The remaining 4 arms, control and 3 experimental, went through to the final analysis. Around the time we dropped the celecoxib, we also decided that it would be very interesting to start looking at abiraterone, because obviously the drug was clearly spectacular in the CRPC setting. It was a new class of drug, and we wanted to incorporate it in the trial. And in the end, we figured we could incorporate it in the trial by amending the protocol rather than by setting up a new separate trial, which we also considered, but didn't do, obviously, in the end. And we've since added a whole series more arms. So we're slightly further on over here now than when I made this slide. We're just getting towards the tail end of 2 repurposing questions, metformin and estrogen patches. So just to illustrate how effective it is, adding a trial arm by protocol amendment, and in effect setting up a new trial by amending an existing one rather than by setting up a new trial. This is how long it took us to get the first patient randomized in each of the participating centers. And you can see it took us 5 years to get the first 80 centers open. I mean, this just reflects the reality that people kind of do this sort of thing as a hobby in their spare time, rather than it being their core business. You know, everybody's very busy treating their own patients. When we set the abiraterone arm up, we were very nervous that people would just say, oh, this is just too complex, adding another arm in, the admin's too difficult. And we kind of did it in an all or nothing basis, that you either added the arm or you closed the trial in your center. So there was a very big risk that when we amended the protocol, we would shut the trial. But actually what happened was this. You can see it took us 3 months to get the first patient into the first 80 centers, and by 2 years we were up to 120. So abiraterone actually had the effect of increasing the numbers of centers taking part, and obviously we got the thing set up very quickly in terms of first patient in, so we literally hit the ground running fast and flat out. And just to show that's not a fluke, we've done it multiple times since. And the T2 has slightly different inclusion criteria, which is why it's taken off more slowly. But for all of the other arms that have, you can see the first patient ins happened extremely quickly and very consistently quickly. So it's a very powerful way of setting up a new trial. And this reduces costs. You get faster answers because you're recruiting faster. It's an efficient way of improving patient outcomes. It's attractive to patients because you increase the chances you go into trial and get a new treatment. And 5,000–6,000 people have now gone into trial, got the new treatment and had survival improved. So there's been absolute direct survival benefits to patients from going in STAMPEDE. And you get opportunistic additional comparisons. And I'll show you data from the patients from the overlap between docetaxel and abiraterone, which effectively means we randomized docetaxel versus abiraterone. I'll also show you some data from the translational studies. We've got numerous different translational studies running. I'll just focus on a few aspects. And of course, you get, if you're recruiting these numbers on this scale across every oncology center in the UK, you've got absolutely completely convincing real-world health economics. So these are, every oncology centre is recruiting. So whatever we do is very representative of real life, rather than being a subset of patients in academic centres. So moving on, I'm going to have a quick look at docetaxel, because there's been a lot of controversy around whether volume matters in response to docetaxel. So within STAMPEDE, we've got both high and low volume patients in the metastatic group, because we didn't put any selection in on that, and have looked at that retrospectively. But we've also got patients to the left of that in the M0 space. So we can look to see whether the effect extends into M0 or not. So first, just looking at the relevant trials here, we've got CHARTED, which of course was the first to report docetaxel results. Oh no, sorry, JETIC-15, the first to report docetaxel results, then CHARTED, and then STAMPEDE, and we can look at that as two trials, ADT plus or minus docetaxel, or ADT plus zoledronic acid plus or minus docetaxel, because we've got a zoledronic acid docetaxel arm. And you can see in this context, all the trials are consistent. So although JETIC-15 was reported as a negative trial, its results are completely consistent with the other three. And the point estimate for the hazard ratio comes actually very close to the point estimate we got from the docetaxel arm. And that's obviously a very consistent and important survival improvement, 40 to 49% at 4 years for men with metastatic disease. It's the metastatic subset. And I think it's worth remembering this, because the consequence of not giving docetaxel to men with low volume disease is that you're depriving them, I believe, of a survival benefit. And I'll come back to this. So because of the controversy generated by the CHARTED group's results, we went back and did a longer term analysis from the docetaxel data. So this is data we presented at ESMO in 2019, and we went and did the CHARTED classifier. So the first thing to note is that the patients in STAMPEDE are rather different to the patients in CHARTED and JETIC-15. So I've split this by de novo and relapse, and you can see that virtually all the patients in STAMPEDE are de novo, only under 5% are relapsed, and the proportions are almost identical between high and low volume in STAMPEDE. In contrast, in CHARTED and JETIC-15, there's a far higher proportion of relapsed patients with prior local therapy, but also the proportions are different. So the prior local therapy patients were much more likely to be low volume on relapse, whereas the de novo were much more likely to be high volume. So the high and low volume comparison is not comparing like with like in those two trials. So these are just the outcome measures from STAMPEDE. So this just shows you how our patients divvied up between high and low volume. We weren't able to reclassify everybody. We couldn't get hold of all of the scans, or the scans didn't exist because people had, say, PET scans instead of bone scan or whatever. But you can see it's a near 50-50 split, high-low, slightly more high than low, all de novo. So for failure-free survival, this is for the whole population. This is almost identical to the first analysis, 0.66. And then those are the 5-year survivals, 13 versus 21%. So that's failure-free survival. This is overall survival. Again, slightly softer hazard ratio than the first analysis, 0.81, but still highly significant. The hazards were non-proportional, so the effect is not the same all the way along. So these curves, according to our modeling, really do look like they come together at about 8 or 9 years. So you've still got if you look at the restricted mean survival time difference, you've got a gain in survival, even though the curves eventually come together. And the 5-year survival estimates are here, 37 versus 49%. So a very big gain at 5 years. If we split by disease burden, again, I just highlight there are very few patients out here, so we ignore the crossing and steppiness of this over here and the same over here. Focusing on the 5-year outcomes, what we can see is that the gain in absolute terms, so firstly, the hazard ratios are very similar for high and low volume, unlike charted. Secondly, the 5-year survival gain is bigger in absolute terms for low volume than it is for high volume. So you've got a 10% gain in the high volume ones and a 15% gain in the low volume ones. So again, not treating low burden de novo patients, I think you're depriving patients of a survival benefit. That's not to say you can't get it another way with abiraterone or whatever, but a lot of countries won't fund upfront abiraterone or enzalutamide or APA or whatever. And this is just the forest plot showing that on failure-free, progression-free prostate cancer-specific survival, all of the effects in this are in the same direction with no suggestion that there's heterogeneity of effect. So the test for heterogeneity of effect, the magic number here is 0.1 usually. And if less than 0.1 suggests you've got a different effect in different subgroups, these effects are obviously a long way different from 0.1. So what about M0 disease? So this is data also presented at ESMO in 2019. And because we thought there might not be enough OS events, we did mPFS, metastatic progression-free survival, which we've got data on, and failure-free survival. So for the failure-free survival, the hazard ratio is very similar to the M1, which is 0.66, and is less than, the confidence is also less than 1. But whilst there's a suggestion of an mPFS benefit, clearly it's not very convincingly positive, even with the extra follow-up. And so this just summarizes these effects in the forest plot. So this is failure-free, progression-free, metastatic progression-free, overall survival, and prostate cancer-specific survival. So you can see the point estimates are all less than 1, but it's only for failure-free survival does this not include 1. So if we look at 5-year survival or 5-year percentages free from events, again, you've got a significant difference on failure, a smaller difference on progression, metastatic progression, which was the primary for this analysis, a very small gap, and ditto for these other 2 outcomes. And if you calculate it the other way, if you work out what the restricted mean survival time difference is, you can see that this potential translation survival difference translates into a very small difference in restricted mean survival. So on survival grounds, you can't really justify giving upfront docetaxel in M0. On failure-free survival, maybe you can. Not relapsing is still a worthwhile outcome potentially for patients. So there's not no effect, but there's not a survival effect. Moving on to other things that we can get from opportunistic comparisons. We were interested in what the effects were of radiotherapy in the M0 group. So we've got 2 groups here. We've got the high-risk localized T3/4 PSA above 40, Gleason 8 to 10. You have to have at least 2 of these, or radiologically node positive with any T Gleason or PSA. And we were basically, initially we were permissive as to clinicians just chose whether they could give radiotherapy for both groups. From 2011, with the 2 randomized trials, PRO7 and SPCG7, we made it mandatory. But so prior to 2011, we could look to see what the impact was of radiotherapy in this group. It's not randomized, but it turned out that institutes were just decided to give all of these patients radiotherapy or none of these patients radiotherapy. So it turned out they were quite well matched. So we did an analysis of this on the control arm patients only. So at the point where we did this, which was a few years ago now, 788 were non-metastatic. Some of those were the prior local therapies with a relapse. And so there were 721 with no prior local therapy. So this is failure-free survival. We picked 3 years. As I said, these groups were not randomized, but actually quite well matched. And you can see that you've got an effect very similar to PRO7, the UK radiotherapy trial, on failure with radiotherapy versus without. So it's consistent with the published literature. So this encourages us to think, well, if we see this with the M0, whatever we see with the node positive will probably reflect the trial that nobody has done. which is ADT plus or minus radiotherapy. And this is what we saw. You halve the risk of relapse at 3 years by adding radiotherapy in node-positive patients. And this is radiotherapy to the prostate plus the nodes. So the relevance of this is that, as I said, the effects are consistent with the randomized trials that exist. So it supports using it in patients with node-positive disease where there are no randomized trials. It therefore strongly supports the use of radiotherapy in node-positive patients. And it's also worth mentioning that, of course, a lot of these patients, if you PET scan them, would now be considered metastatic. So it supports the use of radiotherapy to the primary in patients who are M0 on conventional imaging, but then turn out to be M1 on PSMA PET. So I think these data are important given the current trends in imaging. So the next thing that we've just looked at, and we looked at this with the docetaxel long-term follow-up, is what's the interaction, if we look at between getting radiotherapy and having docetaxel. So this is a little bit complicated. So if we look at progression-free survival with and without radiotherapy, you can see no radiotherapy, radiotherapy are the dark circles. So N0 and N plus combined, you've got this gap. If we separate it into N0 and N plus, the effect appears to be driven more by the N0s than the N pluses. So presumably you've got less of an effect if you're irradiating patients with nodes, because probably a lot of them will have occult metastases. But on all of these groups, it translates into a gain in restricted mean survival time. So what happens if we add docetaxel? So this is failure-free survival in both arms without docetaxel, with docetaxel. So as I've already shown you, docetaxel improves failure-free survival, but with and without radiotherapy. But the gap is smaller with docetaxel if you have radiotherapy as well, and if you don't have radiotherapy. So it implies some sort of competitive effect. And then if we look at progression-free survival, that difference almost completely disappears. So our conclusion would be, there's no point in giving docetaxel and radiotherapy. You should give docetaxel or radiotherapy, but probably not much point in giving both. So I think there's probably no real role for docetaxel in M0 hormone-sensitive prostate cancer, but there is a role in M1. So looking at all of that, docetaxel consistently improves failure-free survival across the spectrum, and it improves overall survival in M1 hormone-naive prostate cancer, regardless in de novo patients, which is what we've got in STAMPEDE, of metastatic burden. And I think the difference between what we've seen and what Chris Sweeney and others have presented from Chartered and from JESIC 15, I think is explained by the de novo versus relapsed rather than by high versus low volume. Also, the data on non-randomized analyses is consistent with radiotherapy improving survival in M0 disease, and obviously we've got the data from the M1 disease as well now. I think depending on your funding environment and other considerations, docetaxel should still be considered as a first-line option alongside AR targeting agents for all de novo metastatic patients, regardless of stratification of disease burden. So moving on to hormone-sensitive prostate cancer and AR targeting, obviously STAMPEDE has contributed to the literature here alongside Latitude. And then you've separately got the ENZAMET and TITAN trials with the non-steroidal anti-androgens. And if you line all these up, you've got a very strikingly similar hazard ratio. But the interesting thing here is these two trials had upfront docetaxel as well to varying extents. And my eye is certainly drawn to this, which is these hazard ratios are slightly softer than these hazard ratios. Now, you have to be careful comparing hazard ratios between trials, but it's certainly worth looking at this in more detail. So this is TITAN, and only a relatively small number of patients having docetaxel in this group out of the total. But it's striking that in the group that didn't get docetaxel, we're now down to a hazard ratio that is very similar to the abiraterone one, if not identical, whereas this one very substantially includes one, but obviously with a relatively low level of exposure. We see exactly the same effect in ENZAMET. You've got a marked dilution of the hazard ratio if you've had docetaxel. And again, the confidence includes one in the docetaxel group, but not in the other group. And if we look at the survival curves, this is the docetaxel cohort, this is the no docetaxel cohort. So this looks very like the abiraterone data. I haven't shown you the curves, but I'm sure you know what they look like. Whereas here, you've got a failure-free benefit, but really very little to suggest you're ever going to see a survival difference here. Now, I know these are immature data and there's other data to come, but it's so far, for me, the conclusion would be that you've got weak, at best, evidence of a dual benefit. And it's worth pointing out that no trial combining anything with docetaxel has come out better than docetaxel on its own. So there's a whole morass of CRPC trials of docetaxel. This is docetaxel plus something else, which is essentially kind of one way of looking at this, and they are all negative. So basically you have to pick either an AR targeted therapy or docetaxel would be my take on this. And then the second thing to point out is around volume. So I haven't shown you the data in the interest of time, but I think for docetaxel, you've got, I don't think any good evidence you've got a difference in de novo patients, given that that's what we saw in STAMPEDE. There may be differences in relapsed patients. There's not enough patients in STAMPEDE to look at that. For abiraterone, because we had both high and low volume, we can say that there is no predictive benefits. It works just as well. I haven't put the slides in, but we've published the data. And the ENZA and APA trials were volume blind. So basically, for most of the patients, volume is not predictive of benefit. It's only prognostic. Of course, more disease, you do worse. And then for radiotherapy, we've got a volume effect, which I will show you next. Or later. Just moving on to docetaxel versus abiraterone. These are the docetaxel patients in sort of mustardy yellow. These are the ABI patients. So we have an overlap of about 600 patients randomized head to head. What we see is that failure-free survival strongly favors abiraterone, but you've used up your best salvage therapy to the point of exhaustion, whereas you can re-challenge with docetaxel patients. So we see a catch-up, A, because these patients get ABI later, and B, because they can potentially get docetaxel other chemos. And you can see by the time we get to prostate cancer-specific survival, there's not really much difference between these two groups. In fact, the overall survival actually shades in favor of docetaxel in this head-to-head group. So another way of trying to split these is on quality of life. So this is data Hannah Rush, one of our research fellows, presented at GU ASCO this year. So this is quality of life out to 2 years. Patients are censored at relapse. So this is pre-relapse quality of life. And what you can see is with docetaxel, you get a dip, which you'd expect, but the dips last out to a year. So the effect is actually rather more profound than I have to say I would have expected. Whereas ABI, you get an increase compared to the control arm, which is in black here. I haven't put the confidence intervals on this. So you've got very convincing evidence, quite a sustained quality of life benefit from upfront ABI compared to upfront DOSI. If you look post-progression, there's no reciprocal benefit for docetaxel. It doesn't, from the docetaxel arm patients, there doesn't appear to be a catch-up late effect from later, presumably reflecting the sort of variety. So the next thing was treating the primary. So just the randomization here includes around 20% of patients getting docetaxel because we changed the standard of care for the later patients. At the top is survival, at the bottom is failure-free survival, and we split by high and low metastatic burden using the charted thing simply because that's the most widely used one. And what you can see is you get a big failure-free benefit in low met, no benefit in high met, pray that forward, and not surprising, no survival benefit here, but a survival benefit here with a hazard ratio of 0.68, which is not unadjacent to that seen with the AR targeting agent. So this is a substantial benefit. And as the HORAD trial did an exploratory analysis splitting on 5 Mets and got pretty much identical numbers for their estimates. So there's no particular reason why 3 versus 4 and above is the right split. So we've done some exploratory analyses on the relationship between the number of bone metastases and the point estimate of the hazard ratio. These are model data. It's actually been accepted now in Annals of Oncology, but not published yet. And you can see, so this is the charted low volume group. So it does identify the group that get the biggest benefit. But you can see that for failure-free survival, the benefit from irradiating the primary hasn't completely petered. It doesn't even, the upper bound doesn't even cross 1 till you get to 9 Mets. For overall survival, your benefit is diluted by other things happening, but this still crosses the line at 8. So the benefit from treating the primary almost certainly extends beyond 3 Mets and may extend as far as 8 or 9 Mets. And another way of looking at this, we quantified the uptake on using something called the bone scan index. And you can see that this just quantifies the percentage of skeleton affected. And you can see in the lowest quartile, you get the biggest benefit. You're still seeing some benefit in the second quartile. Quartiles 3 and 4, you're really seeing no benefit. Play that forward. In the lowest quartile, it plays out to a survival benefit, but not in the other 3 quartiles. So the lowest quartile is very similar to the charted low volume, of course. So it's another way of doing that. The other thing, just by the by, is this issue around any volume of lymph nodes is low volume. Now, clearly that can be a solitary 2-centimeter lymph node in your paraortic region, or it can be lymph nodes the size of tennis balls all the way from your chin to your pelvis. And so this is work that another of our research fellows, Anya Harron, presented at AUA this last summer. And this is in arms A versus C. So in all of these groups, docetaxel improves overall and failure-free survival. But so what we've done, the split here is between up to 5 and greater than 5, which was what gave us the biggest separation. So this is a retrospective analysis, of course. And you can see that for failure-free and, sorry, I'm not sure what we've got here. For failure-free and overall survival, whether you've got standard of care or standard of care plus docetaxel, you've got the same separation. So basically, the volume of lymph gland disease is in itself prognostic, as you would expect, of course. So lumping them all in one single classification as all being the same low volume is probably an oversimplification. And just the other thing I would highlight here is that we've now shown that radiotherapy improves survival in low volume M0, and other groups have shown it in N0 high risk. So it makes it even more plausible that if you're nodes positive but M0, which is the group sitting between those 2 groups, and that where there are no trials, that you should have a survival benefit. I don't think anybody will ever do the trials. There are no randomized trials, of course, published yet in treating synchronous oligometastatic disease, which is the arm that we are hoping to start, not hoping, we are funded to start, we're in setup. We appointed a research fellow to help us set this up this morning. So, and we're very much hoping to collaborate with groups in North America, Germany, and the ANZUP group in Australia and New Zealand as well in running this. So Dan Spratt has been leading on hopefully getting this set up in North America. And it's been widely adopted as a standard of care. So I know that there is controversy in America in particular as to whether this is a standard of care, but EAU, NCCN, ASCO slightly more hedged, and NHS England have all said this is part of their standard of care they consider now. I'm going to say a little bit about sequencing because you can get a bit of data out of that from the trial. So if we compare STAMPEDE docetaxel charted and STAMPEDE abiraterone, we've got very similar median survivals. This is across the trial, but very different mixes of salvage therapies, giving us the same survival. So if you look at AR targeted therapy for STAMPEDE-ABI versus STAMPEDE-DOSI, there's much more. So it's kind of implies that exactly what you get doesn't matter. You're going to get the same sort of survival. These are control arm survivals, not experimental arm survivals. Conversely, in this group, we can see what survival difference if you start with standard of care DOSI versus standard of care ABI. And I've already shown you that there is no survival difference, but the salvage therapies are very different. So in green is the ABI arm patients, and they overwhelmingly got DOSI as their next therapy. And whereas the docetaxel arm patients, some of them got DOSI as their next therapy as well, but far fewer of them. Conversely, this is the AR targeted therapy. If you went in the docetaxel arm of the trial, you were very likely to then get an AR targeted therapy next. Whereas if you went in the abiraterone arm of the trial, you were much less likely to get an AR targeted therapy next. So as I've highlighted, you ended up with the same cause-specific survival, but with a completely different sequencing of treatments, you'd end up with the same result. So again, you'd conclude that sequence of treatment probably doesn't matter as long as you get the right treatments. And I'm just going to quickly highlight some of our translational research. So this is something that we've put a lot of effort into recently. So a lot of people need to be name-checked in this. David Durnley, Malcolm Mason, Noel Clark, Matt Sides, and Max Palmer. This is currently led by Gert Attard, and again, I'm sure these are all people you know. And we focused on the arms that have delivered positive survival results so far. So docetaxel plus the zoledronic acid pair, the docetaxel, the ABI arm, the ABI-ENZA arm, and we're just pulling together grant applications for this, the RTM1 arm. And we've got a lot of different research going on, looking at routine data as a supplement, looking at various aspects of omics and imaging. So I've already shown you some of the imaging translational analyses we've done. I will skip through some of this and just show you this. So this is gene and pathway alterations in newly diagnosed high-risk prostate cancer, showing essentially this looks like what you would see from CRPC, with the big exception that the AR pathway mutations are much less prominent in newly diagnosed. You acquire mutations in your AR pathway with treatment. You don't have so many of them at presentation. And this is another aspect that we're looking at. We're looking at percentage genome altered, and basically that is itself prognostic as well. This is work that Emily Grist has done, another of our research fellows. So this is these are analyses in progress. So I think this is my last slide. Yes, it is. So I think we've seen from STAMPEDE and other trials that ADT plus one drug therapy improves survival in metastatic hormone-sensitive disease. Radiotherapy plus improves survival in low volume only, but exactly how you define low volume is clearly something that merits further research in itself. There's no good evidence to support two drug combinations at the moment in metastatic hormone-sensitive prostate cancer over sequential use, I don't think. And that in turn does shed some data of relevance to the best sequencing, suggesting there probably isn't a best sequencing as long as you give all the drugs. And obviously all the sequencing questions are going to get more complicated with the licensing of PARP inhibitors and the likely, I suspect, licensing of PSMA theranostics as well. Plus, obviously, we will be hoping to generate data on upfront state saver as well. So that is my last slide. Thank you for your attention. So I'm happy to take questions. I don't know how best to do this.
Please feel free, everyone, to punch in your questions in the meeting chat, and I'll be happy to read them off. And I'm sure there's plenty of questions out there as you get going on that. Just a brief comments from my viewpoint as a radiation oncologist. I'm personally very excited at the specter of the results of ARM-M, which I think could be very sort of paradigm defining ahead. And I hope we have the opportunity to open that arm here in the U.S. In terms of treatment to the primary and low volume metastatic disease. This is something I think, at least from my vantage point, we are doing more and more frequently here in the United States. Of course, with a different healthcare economics setup, it's oftentimes challenging to have insurance companies agree to pay for that treatment. But I think with the global sort of guidelines endorsing that approach, hopefully we'll see more and more of that in the United States.
So I'm interested in that. So what, I mean, obviously in the UK, the way the NHS prices this stuff, radiotherapy is very cheap. Whereas the drug treatments you might give instead, like abiraterone, are very expensive. So as you saw, NHS England has just reviewed the options for newly diagnosed disease, and this was their #1 recommendation of things that purchasers should commission out of anything in the NHS, vaccinating babies or anything. This was their highest recommendation for new commissioning, because they viewed it as so cost effective and clinically effective.
I wish we had that kind of a state here, but here getting approval for radiotherapy reimbursement can oftentimes be a challenge.
The other thing actually about the radiotherapy, and again, I don't know, because I think you pay per fraction, don't you? Is that NHS England's look at the data. I didn't go into the fractionation, but we permitted 2 fractionations, a sort of 36 and 6, 1 fraction per week. So not quite full-on radical, stereotactic radiotherapy, but not far short. And 55 in 20, which again is not quite full-on radical dose, but we were concerned when we set the trial up about not inflicting toxicity on men with advanced disease. And they came out equally effective. So the commissioned preference for the NHS is 36 and 6. So it's you're only paying for 6 fractions. Obviously, the planning is the same either way. So just looking at I'm just looking at the question.
Yeah.
So something was just posted about waiting to give abiraterone in hormone-sensitive disease. Well, that I didn't show you the full data set, but essentially that was what we tested in both Latitude and Stampede, and the answer is you get quite substantially inferior survival if you wait until you've got CRPC, because as I think I showed, the patients cross over to abiraterone on the control arm, but they have a survival that is quite substantially inferior.
We've also got a question from Dr. Sain. Maha, if you're on, would you like to just read your question, or I'm happy to read it for you?
No, that's fine. Thank you. Nick, very nice job. Thank you. I call Stampede the gift that keeps on giving. So it's going to continue. So my question to you is this: there is really no data that I'm aware of on patients who have been, let's say, on ADT plus Abi per Latitude, who then progress from hormone-sensitive to castration-resistant disease, and you give them Enza. We know that in the real world castration-resistant space, really Abi after Enza doesn't work, and Enza after Abi is not great either. So the question is, in this context, how does that work?
Yeah, so this is one of the things that's just coming back to, I sort of rather skated over it. So we're very interested in drilling into this with the NHS data sets, because the NHS, it's a single payer system across the whole of England, and separate single payer systems in Scotland and Wales and stuff. So there's a few questions we're looking at. So that is one of them, and also the question of how well do you respond to docetaxel after abiraterone, if you and so on. So there's a whole raft of similar questions that we've worked out the methodology. I've just had a PhD student finishing this, that we can calculate failure-free survival from NHS stats. And this is something we'll want to look at. My gut feeling is that you probably don't get terribly good responses, rather like CRPC. But I can't quote you data from the trial. It's something we want to look at. But I think the thing we're going to look at first, my other concern, though, is that a quarter of the men who we started on abiraterone in Arm G are still on treatment, and the arm finished recruiting in 2013. So we've got extraordinarily long exposures to abiraterone, and so there is a suspicion that the survival might be a bit better with docetaxel up front, and that might be because of non-cancer deaths So we're starting to look at things like, so I've got an MD student looking at cardiovascular mortality and also things like hip fractures. Because obviously if you fall over, fracture your hip, a lot of patients never recover and die. So it's a lethal event. So that stuff is very poorly captured in the trial records because, you know, old man falls over, fractures hip. You know, the orthopedic SHO almost certainly isn't going to tell us or even think it might be relevant. So I think there's a few things that we're going to look to answer from the hospital episode data.
Well, thank you.
Are there any other questions for Professor James? Please feel free to punch your questions into the chat box or just speak up. I don't want to hog the discussion, but I have a question. Looking at the results of STAMPEDE Arm G, and in particular looking at the non-metastatic group failure-free survival benefit with the addition of abiraterone of a hazard ratio of 0.21. I recall your presentation at ASCO. I was in the audience, and I can't recall how you articulated, but but I think you explained that you would not expect a different outcome in terms of overall survival, even in the non-metastatic setting, if you're incorporating abiraterone earlier on in the course of treatment. How has that changed your practice? How frequently are you incorporating something like abiraterone up front?
In the EM0s, well, we're not allowed to. Sorry, I'm just trying to find, because other people won't have seen the data. If you just bear with me a second, I will open, if I can find it, the relevant presentation. I might not have it to hand. So in the M0 part of the abiraterone data, what we saw, sorry, I will find it because it's easier to talk to it with the data. So I have so many presentations with STAMPEDE. What we saw was that the failure-free survival benefit of abiraterone extends into the M0, just as the docetaxel benefit does. Unlike the docetaxel benefits, though, we also saw a very strong trend towards a PSA. I'm sorry, no, I can't find it. We saw a very strong trend towards metastatic progression-free survival being positive as well. Now, from Chris Sweeney's ICECAP data, there's a very strong evidence base that metastatic progression-free survival will, in due course, predict for overall survival. So what we haven't published the data that we presented at ESMO on that deliberately, because and when we presented it at ESMO, we didn't do formal stats on it. We just showed the curves. We didn't calculate the hazard ratios. Well, we did, but we haven't put that out in the public domain. And what we're planning to do is redo that analysis next year and publish it, pooling the data from Arm G with Arm J M0. So Arm J is abiraterone plus enzalutamide. So that obviously doubles our sample size and increases our follow-up. So we are hopeful that what we will show is that giving abiraterone with or without enzalutamide in the M0 space, when you combine it with radiotherapy, will improve overall survival. And I think by that time as well, abiraterone will be either off patent or nearly off patent. So I think that will make it much easier to justify centers using it. And that the huge attraction of that as well is that we only gave 2 years of ADT and 2 years of ABI in the M0 space. We didn't continue it to progression. So A, your price is fixed, and B, your risk of long-term toxicity is also fixed. It doesn't keep on increasing like it does with indefinite. So at the moment, we can't use ABI or ENZA or anything in the M0 space, but we think that if what we saw when we did the previous analysis, exploratory analysis, the M0s holds good with more follow-up, and I bet it does, then I would hope that would be practice changing.
I have a question here posed by one of my GU radiation oncology colleagues, John Calafrocal, and he was wondering that in your experience, or just if you have any comments in general on what would be the best relative radiosensitizing potential between Lupron, Zytiga, docetaxel, or any other AR targeted agents when combining with radiotherapy up front.
Yeah, that's very interesting. I mean, it's always been a bit surprising to me that androgen deprivation therapy appears to be a radiosensitizer, because kind of in a sort of rather hand-wavingly vague way, you'd think, well, anything that slows down cell division should make cells more resistant to radiation. But very consistently, radiation plus ADT is better than radiation on its own, say, in a whole range of trials. And what we're seeing with abiraterone appears to, looking at the analyses within the abiraterone part of the trial, it appears that the benefit from abiraterone is actually biggest in the cohorts who also got radiotherapy. That all the point estimates for benefit are more impressive in that sub cohort. So it does suggest, and the maths of it suggests it's synergistic. So it does suggest that ABI is a radiosensitizer. Now, we obviously haven't got an ENZA-only arm in the trial. We will have an ABI-ENZA arm, but the trouble is the effects are so big with ABI on its own, it's hard to see we'll be able to conclude very much from adding ENZA unless it somehow makes it worse. That would be the only conclusion I suspect we can draw, which hopefully it won't do that. Obviously, there's the ENZA-RAD trial, and there's the apalutamide trial, the name of which escapes, I think it's Atlas, isn't it? Looking at apalutamide essentially as an adjuvant / radiosensitizer. So those trials will read out in due course, and we'll be able to compare and contrast. But the best answer I can give is at the moment, any form of ADT, we don't specify which one you should have in the trial, so I can't give an opinion between Zoladex and Lupron, say, appears to work well, and it appears that abiraterone added on top works even better. But I think the data, needs to be hardened up, which we hope to do next. Sorry, I'm saying next year. I mean this year. No, 2021.
Are there any other questions for Professor James?
This is Maha. I have one final question. Nick, in your trials, when you're looking at the combo of AR targeting with DOSI, which I have to say, just based on whatever is available, it doesn't look very promising as a combination, but it'll be interesting to see. Have you had your translational group worked at potential pathways that are, like, let's say, antagonistic or collaborative, and the explanation as to why is it that not dumping the kitchen sink doesn't work, and sequential would work? Why would that be?
Sure. I mean, obviously, you and I both know very well that some patients will respond very well to abiraterone in the CRPC setting, where you're kind of assessing the response, and some will not respond as well, and ditto for docetaxel. Some will respond well, and then others won't. And you'll also see patients who will respond well to DOSI, when they get it, but not respond to ABI, and vice versa. And some patients will respond to both. So there's got to be biology underlying that. It's a bit harder to measure it in the upfront setting, because obviously everybody pretty much gets a response to ADT. So you can't really measure response then. So you're left looking at time to progression. So Gert's et al.'s been busy collecting in, we have got about 5,000 sets of tissue blocks now, from arms A, the control arm, C, the docetaxel arm, and G, the abiraterone arm. So we're going to try and identify things that might underpin those differences in response. But right now, I don't think anybody's got a very good handle on what those differences might be. But they must be identifiable, though. There must be biological difference.
You would think, because because I mean, like anything else, even when you have the best of responders, to get a complete response is not very possible. So there are cells sitting there that are necessarily, they may be dormant, but there may be some cells that are not so dormant, but should be susceptible to taxane or to chemotherapy. I mean, in breast cancer, you have that combo kind of work. For some reason, prostate is not the same.
Yeah, actually, I'm going to reshare one of the things I put up, because the other way of looking at this question is, rather than trying to identify who's going to respond to Abby, who's going to respond to Dosi, there's another question, which is, I'm sorry, I lost my Zoom thing to share it now. Which is, can we identify people who don't need either? So this is Emily Grist's work with percentage genome altered, and this is failure-free survival. And essentially, if you've got a low percentage genome altered, you can see it around about 5 years, but not very many patients have relapsed. This is the lowest, whatever, this is up to 10%, whereas the other groups all run together, and the same applies to survival. So rather than, so the other way we're looking at this question is, can we identify the really good responders to ADT on its own and not give them anything extra, is another way of looking at the same question. And so this is turning this into a continuous variable impact on the thing. So at low percentage genome altered, you've got very little benefit on survival. The benefit is mostly in the high percentage genome altered, as you might expect. These are the more abnormal tumors. So we're looking at it from two directions. One is predictive with respect to drugs, and the other is prognostic with respect to picking people who don't really need much extra.
Okay, we are getting close to the end of the hour. Let me thank Professor James again for his wonderful talk. And I think we had a nice multidisciplinary audience today who are all looking forward to what STAMPEDE will show us over the next few years.
Thank you very much. I think I'm joining your residents for a Zoom call now as well. So I shall duck out of this one and join the other one.
Thank you again for doing that. You should have an email in your inbox from one of our chief residents, Eric Nesbitt, and he will, and they really look forward to meeting you. So thank you.
Fantastic. Okay, excellent. All right. Thank you very much. Bye, everyone. Have a good day.
Thank you.